Thank you very much. So hello and welcome to our talk this morning on the topic of how do we assess the competence of doctors. Now you may have a professional interest in this topic, but it's quite safe to say we all have a personal stake. When either we or our families go and see a physician, we really hope that whoever has been assessing competence has been doing a good job. So let's keep it on a personal level and ask the question, how do doctors choose their own doctors? How does a doctor choose who will take care of their mother? How does a doctor determine who has the competence to become their partner and share in the responsibility of their day-to-day work, taking care of patients? Well, the first thing you should note is that doctors feel very confident that they do know who to trust and who not to trust. They feel very confident that they can assess competence. They think this is a task that can be done well. But here's the catch. They only feel confident if they've had a very close personal working relationship with the candidate doctor. And I don't mean that they just work in the same town or the same hospital or even on the same ward or even in the same clinic. They're talking about a relationship where they have frequent conversations about the cases that they see, where they're working with the same team and they can observe how the doctor interacts with the team and hear what the team thinks about the doctor. They hope to get glimpses of that doctor with their patients from time to time and glimpses of the doctor with students and residents and listen to what students and residents are saying. So when all those observations are added up, doctors feel pretty confident about whether this is a person who is competent. And not only that, they feel they can describe which categories of competence the person is strong in or weak in. Now, what do they do when they don't have that personal exposure to the candidate doctor? Well, they look to talk to somebody who did. And there are two characteristics they're looking for. They're looking to talk to somebody they trust who is competent and can make good judgments about competence. And the second thing they're looking for is, did that trusted colleague actually observe often enough to make a good decision? And to find that out, they ask maybe 3 or 4 probing questions, such as, so how's her knowledge base? How is his clinical judgment? Does he make good decisions in the real world? Is she a people person? Does she get along well with the team? Does she treat patients kindly? Is he responsible? Is he dependable? Is he reliable? And that's it. On the basis of those questions and the answers they get from a trusted colleague, that's how they make the high-stakes decisions of who's competent in their own world. Now, is there anything missing here? Well, do they ask for transcripts and say, I'd like to see the scores on the most recent tests and exams? No, they don't. Do they ask to see the ranking of this candidate doctor in their class or in their cohort of residents? No, they don't. Do they ask to see the list of evaluation objectives that the program says they use to do evaluation? No, they don't. And yet, these parameters are exactly what you and I who design assessment programs are trying to produce. So why is there a disconnect between what doctors really do when they assess competence and what our institutions do? And we think the disconnect comes from some fundamental different assumptions. The doctors are behaving as if they believe this, that the task at hand is to assess high-level, high-order cognitive skills that have to be applied, often simultaneously, in a complex environment that's frequently changing. And they think the only way to validly assess that is to put an expert who's doing frequent observations and making judgments. But that is not the assumption that our institutions start from when they design assessment programs. They start with assumptions that come from best practice in higher education. And I'd like to mention 2 of these assumptions because they are so true and valuable in one setting, they become dangerous when we misapply them in the context of competency assessment. The first assumption goes like this. If you're going to assess anything, you need to know what you're looking for. You need to describe the competence. You need to describe the outcomes. And this is the kickstart for an industry in our medical profession called writing evaluation objectives. And evaluation objectives are very important. Our program writes lots of them. We write them specific to our specialties. We write them because the public has expanded the competencies they expect of doctors. And we find they're useful for designing curriculum and guiding students as to what to look to learn. But is it true that writing long lists of evaluation objectives actually improves the observations of learners in the workplace or the judgments made by experts? We think that's an assumption that needs to be contested. Now, the second assumption, which is so true it's dangerous, goes like this. If the stakes are high in an assessment, then you must remove subjectivity. You must make your assessment process and tools objective and reliable. And trust me, we've all spent lots of time to ensure that our examinations and our tests are objective and reliable. But what happens if you're asking an expert to help you do an assessment and you try to give them tools that are objective? There is some evidence that if you overstructure the tools that a clinical preceptor uses to make an assessment, you actually decrease their reliability. You actually decrease their ability to discriminate good from bad performance. As an example, surgeons reviewing videotapes of surgical procedures had to use a very structured checklist with Likert scales, or simply a very simple broad guideline to remind them what they should be commenting on. And when they were given the looser, broader guideline, they were far more reliable in distinguishing high-performing procedure from low-performance procedures. So, in our program, of course, like all of you, we use a blend of assessment techniques, but we've done a lot of work on trying to improve the quality and quantity of observations of our clinical preceptors, and more importantly, to improve the clarity and timeliness of their ability to describe who's doing well and who needs special attention. So Shelly, tell us how we do it.
So Mike has set up for you what we think needs to happen. We need to shift the focus of medical education assessment. We're not saying we need to shift the location. For as long as we have been training doctors, they've been in the workplace. They've been with teachers, they've been with colleagues, they've been with patients, they've been with nurses and other staff. But who's been watching them is the question that we pose. It's not enough to have your learners out there and observing what's going on and doing things and telling you what they're doing out there. Somebody needs to be watching them. They need to see them with patients. They need to see them with staff. They need to see how they interact with families. They need to see how these learners are working through cases and making plans for treatment. Somebody has to watch. Now, it's not enough just to say, watch them. What's also really important is that you need to give some guidelines and you need to come up with a way for observations to be documented and judgments of performance to be recorded. So what kinds of guidelines do we need to give? Well, as Mike has said, if you overstructure those guidelines to your experts, you lose the validity of the observations that they make. So in our program, we use something we call sentinel habits. Sentinel habits are very simple statements of big ideas. For example, does the trainee show respect and responsibility for and towards patients, staff, and colleagues? That's it. That simple statement encompasses the very big and complicated idea of professionalism. We have 10 sentinel habits like this, and what they do is they encompass the art and science of medicine that needs to be seen over and over to know whether or not your trainees are progressing towards competence. The other piece that we've come up with is the documentation. How do you keep track of those observations and judgments of what's really happening in front of you with trainees in the workplace? Mike, 20 years ago, came up with something called field notes. These are incredibly simple forms. They record the date. They record the event as simply as 26-year-old female with abdominal pain. They record the feedback given to the learner because feedback's essential in medical education. And they record a judgment about the performance. There's also some tags because all of this is electronic. It goes into a web-based portfolio. Our statements of judgment, again, are very simple. They're not complex scales. They are, carry on, got it. This trainee's nailed it. In progress, there's still some learning to be done. Or stop, important correction. And that's it. Those are our judgment calls on any individual piece of behavior that's observed in the workplace. It's not enough to just collect all of this evidence. Something has to be done with it. And what happens in our program is periodically, supervisors and trainees meet and review all of this evidence of workplace performance, these observations and judgments. They go over all the field notes in the portfolio that have come from multiple contexts, by multiple observers, of multiple demonstrations of workplace performance. And they use all of this to come up with a picture of competency. So think of all those individual field notes as being the tiles of a mosaic. And all those tiles come together, and the supervisor and trainee look at it and say, can we see a picture developing? Is it clear? Can we see that this is going to be a good, competent doctor for the public? Or are there areas where there are gaps? Are tiles missing? Are some of the colors not intense enough to really make out the outline and the details of competence? When we first introduced this idea, we were told, this way lies madness. There is no way that busy doctors can make these kinds of observations and write these field notes. It's just not going to happen. We went into full implementation 3 years ago. We have, at any given time, 150 trainees in workplaces being observed across our program. We are averaging 5,000 field notes per year for those trainees. Why do we have this kind of buy-in? Because we tell our teachers, you don't have to make a global assessment of competence about these learners. You just have to observe and judge what you see in front of you. Ideally, it doesn't necessarily happen, but ideally we would like to see one observation a day that gets recorded as a field note. One observation and a judgment of performance about one discrete event once a day. Is it working? Is the question. Well, we have some evidence that tells us that this particular approach to documenting observations and judgments of discrete performances to develop an idea of competency is working. The first thing that tells us that it's working is the buy-in. Our preceptors are entering thousands of notes a year. And all of those multiple notes, multiple contexts, multiple observations are giving us a good picture of what's happening in our program. Where are our residents getting feedback? We can tell you. Where are they not getting feedback? We can tell you. We can even use this to inform our curriculum. Our second piece of evidence is in the area of remediation. We do more remediations now than we used to do. But that's really exciting because the remediations now are smaller, they're more effective, and they're targeted because we know from the field notes exactly what needs to be remediated. Traditionally, if a resident failed a rotation, they repeated the rotation. And it just wasn't working. Well, it wasn't working because if the resident failed a rotation for something like professionalism, repeating the rotation isn't going to fix the problem. Our remediations are very targeted at what the issue is because we know our residents are being watched. Another piece that gives us an idea that this is working well is we talk to our residents. Now, if we say to our residents, does this system help you learn? They say, well, no, I just do it because I have to. If we ask our residents, do you know how you're doing? They'll say, yeah, I know how I'm doing. I know exactly how I'm doing. Do you know your strengths and weaknesses? Yeah, I know what they are. Do you get feedback? And this is really, really key because if you look at the literature, learners in medical education often complain they just don't get enough feedback. Our residents say, I get feedback all the time. I get great feedback. That's a real success of this system. Our final piece of evidence that this works is transferability. This system has been adopted well beyond our particular program. It's been adopted by other specialties, and recently it's been adopted by the medical registrars of various provinces in Canada to be used to assess the practice readiness of physicians who are trained outside of Canada. It's a pretty big vote of confidence, we think. This system was developed through a lot of conversations with a lot of experts in multiple venues. We're hoping that the presentation and overview we've given you today of this program sparks some more discussion and some more conversations. Thanks.